Hello, I'm Dr. Colm Harney, dental legal consultant at Dental Protection. Welcome to RiskMatters, our latest series of podcasts created specifically for dental practitioners in Australia. As the name suggests, RiskMatters is all about managing risk. In this podcast series, we'll be taking your feedback and queries and putting them to the leading industry experts, getting them to answer the difficult questions about managing risk and working safely. It's about what to do when managing risk matters most. In this edition, we're going to be chatting to Dr. Amit Gurbuxani about audits. So, hi Amit, thank you for joining me. And for those of you who don't know, I'm going to start by giving a bio of Amit. So, Dr. Amit Gurbuxani is a general dentist, educator and practice owner based in Perth and a principal dentist. He's a past president of the ADAWA and a present member of the ADA Federal Item Code Committee, where he works on the development and clarification of dental item numbers at a national level. Drawing on years of clinical practice, teaching and advocacy, Amit has a strong interest in helping dentists understand item codes, compliance, and the real-world realities of running ethical, efficient practices.
Thanks, Colm. That sounds very professional, but yes, I'm grateful to be given this opportunity of sharing, different techniques on, as you mentioned, the topic risk mitigation.
Yes.
How we can use the item codes in a correct manner and make our lives easy as dentists and reduce the risk mitigation from audits that happen by various agencies, organizations.
Yes, I think if we can point our members, mutual members in the general direction of things they should be looking out for and things to do, things to not do, I think we will hopefully save somebody or some group of practitioners a lot of heartache, because these can be very stressful.
And that's the whole aim of this podcast. If members can get a couple of points which make their life a bit easier, they're all very busy practitioners. While listening to this, they go, yep, I can apply that very easily in my practice and make it simplified. Then I think we've achieved what we want to do.
Yes, agree. And I think the reasonable and sensible place to start is with the question, what is an audit? What does an audit mean? What might it look like for a practitioner who maybe receives a phone call or that letter or the email from an entity?
Thanks, Colm. That's actually a very good question. And I thought about a few things in terms of when you ask what is an audit, the word audit itself raises fear. It feels like, someone of authority asking you, saying, hey, what's happening? But generally an audit is basically a third party who wants to know what information that you have used and what clinical steps that you have done and what evidence that you have to support it in order to claim the correct item code. In an easy word, an audit is not something to be extremely afraid of, because in the medical field, audits happen on a day-to-day basis.
Yeah.
The difference between us as dentists and doctors in the medical and dental field is in medical field, a lot of it is covered by Medicare. So doctors are very used to this.
Okay.
But in the dental field, it's actually quite scary when members actually receive a letter, as you said, or a phone call. What's worse is that sometimes a letter will come from an audit perspective, which will actually just tell you that, hey, you're actually, compared to your peers, your billing pattern is a bit higher or is a bit lower. And many times that's not an actual audit. That's just a bit of a information comparison which the health funds or Medicare or someone else may have done.
Yeah.
And that's a bit of a guidance. But members can feel a bit threatened by those type of documentations.
Yeah, that's an interesting point, the last one. So sometimes there's a little kind of almost like a shot across the bows. Hey, we've noticed some sort of outlier behavior.
Yeah.
And it's then up to the practitioner. There may be and there usually is a very good reason, such as maybe a practitioner who goes into elderly care homes a lot and will have a higher rate of large surface GICs or things like that.
Yes.
And dentures compared to their colleagues in regular run-of-the-mill general practice. So there's usually a very innocent explanation.
Totally. One of the perfect examples is graduates who graduate, because I've also been a clinical lecturer at UWA. When we're actually teaching students over there, a lot of students are focused on oral hygiene instruction. You spend a lot of time on oral hygiene instructions. And that's a code that's commonly used in the public sector at the dental school, where students are taught about that. But when they actually graduate and come out into practice, using a code of an oral hygiene instruction on a day-to-day basis, when your peers in your practice have almost taken as partly granted that as part of the conversation, it becomes part of the examination. The member, the new graduate or the member may not be doing anything wrong, but it's the fact that it's a difference from the other members. It raises an alarm in the health funds or Medicare or anyone else, and they may question you, and that's what we term as an audit. Or they might send you a firing bow saying, hey, this is a bit different from someone else, where are you going with it? No, it doesn't mean you're doing anything wrong.
Yes. And that's a really good segue maybe into the next question. In broad terms, what are the reasons that you might, apart from what we've just said, maybe that some little bit of outlier behavior, what sort of broad reasons might a practitioner receive a notification of an audit?
True. That very good point. A lot of times people say that the audits are random. Is it really random? I think there are various factors for it. A lot of it is because of either a past history of that particular practice, where they have been using certain item codes, which we, as you said, is an outlier. The health funds have very complex algorithms. They know to the point where you've bought a new equipment, because suddenly those item codes start coming into it, especially in today's day and world with CBCTs in terms of it. And many times they just want to question, saying, hey, where did this come from? Or you've gone for a course and come back and you've been told to apply this, and you start doing those from Monday onwards, and suddenly everyone in your practice is doing it. So it's a big change from the past protocol of how you were billing or treating the patients.
And I can see that, and
they can see that in real world. And it's funny when you look at some of these complex algorithms from health funds and other people who collect data. Data analysis is the biggest way in which they get targeted. The problem is, when they look at the data analysis, they are only looking at a number. They're not actually looking at the practice, the practitioner,
the context, and the
reason behind it. So just looking at the number is not the right way, but that is what raises the question when it comes to an audit. And that is where the member gets questioned and gets a chance to support themselves. Many times they may be they've got a new machine and they're actually doing a CBCT. They just have to show that yes, we have it, and we have a report. As you know, in WA, all reports have to be reported by a maxillofacial radiologist. So if they are charging for it and they have the report, which we are lucky with, getting it, they're not in any issues. Sometimes it does happen where a patient or the patient's relative and a family member may complain to the health fund. And that's a common one which I've seen happen. Reason being is, sometimes the patient feels a bit disadvantaged. They feel suddenly all the money that they've been putting towards their insurance has suddenly been used up. Can lead to a bit of a problem. One of the common ones, not only from a health fund aspect, is with Medicare. We know with the CDBS, there's a certain amount that's been given, and there are certain times when the patient might go and get in a first bill a certain treatment amount, which might wipe out the whole CDBS amount for the whole entire year. And when the patient then comes back, or the child comes back with the parent, and suddenly they realize there's nothing left in that CDBS fund, they do get a bit upset. If it wasn't explained to them in the previous as to why and where the money was used for what purpose over there. And in general, every single dentist is trying to do the right thing. But if there's an outlier, it triggers question. Then that is pretty much where this comes from. Another common one which happens is workplace grievance. You have sometimes a dental assistant who, or a staff member who may leave on not a great note, and sometimes they may feel whether it's their thinking or whether they're just being vindictive. Sometimes they may actually reach out to a regulatory body and say, hey, this is what I notice is happening in this particular practice. This is how they're actually billing this particular aspect. And by raising that question, then the onus is on the organization to reach out to say, please explain yourselves because this has been questioned earlier. Okay.
Yeah.
So those are some of the common ones I find. One of the other ones which recently starting to make a big difference is if there is a particular change in the schedule, and the schedule changes have now applied where they're actually telling you, for example, you cannot use a certain code for in terms of it. Like in the past, where with an implant access screw, you could seal it with composite, but now that's an integral part of the implant crown.
Yes.
And the closure of the access screw subsequently has a different code.
Yeah.
And those schedule changes are not being updated, especially with the software. Because when the schedule comes out, in the softwares do not keep up with it.
Yeah,
and they lag a little bit in that time on. Because of that factors, the dental softwares, and that's a bigger picture work in progress. But unfortunately, the buck stops with the practitioner and the practice owner, where they then have to make sure that they applying the present schedule codes to it.
Yes.
So if they're using the codes which are not applicable anymore, that's another reason why they could be audited.
Yeah. And that was an interesting one. We did see a flurry of that in the change from Schedule 12 to 13, I think, was it? And you saw a flurry of audits on that for a little while. Yeah. So we've mentioned maybe random, although the context being maybe not so random. There's often probably some kind of reason, but genuinely there can be random audits as well, particularly from Medicare. We do see a little bit on the billing. Maybe outlier billing practices or maybe outlying codes used. In this job, I've discovered many different weird and obscure codes in the glossary that I'd never heard of before. So maybe practitioners who are using these very underutilized codes a lot might come on the radar. So maybe a patient complaint or a workplace grievance, I think. Any other reasons?
Look, sometimes, a specialist, for example, might only be using a certain amount of codes because they are in the specific field. An example, an oral medicine specialist, they are less likely to be using any restorative codes.
Yes.
They're only going to be using the mucosal codes. Now, I should specify, no code in the glossary is restricted to a use by only a specialist or a general dentist. All item numbers are reserved exclusively for the use of all practitioners, whether it's OHTs, hygienists, dentists. This is meant for a profession
within the
scope of practice or what they're doing. But many times, because you might have a specialist who's using only a certain item codes, and that's what's being done, you will have people looking at it and going, they're using only the specific item codes. That number is really high. And you might have even those people being questioned as to, hey, why is this being used? So that's one of the reasons it can happen. One of the common ones also does happen is there are dentists who, for example, travel from practice to practice. Wasn't so common before, but now you're having a few of them who are basically, they might be providing services and they have provided numbers in 3 or 4 different practices. And they are then conducting that same treatment over the 3 or 4 different practices, whether it's surgical extractions, wisdom teeth removal, any particular aspect. But they may have a certain pattern of how they're doing that particular treatment. And that sometimes can get picked up also, because the codes that they are using is very unique to their pattern. And it raises a question mark.
So it is an outlier.
Again. Even though it may be over 4 different practices, but it's a practitioner way of doing it from
Yes.
One of the common ones could be if most people have a certain way of billing or coding, and we do. The truth is we all have patterns.
Yes.
It's in our daily life and everything else. But if those patterns sudden change, or if those patterns increase to a point where it becomes unreasonable for an item code usage, and that's what we talk about padding the system, that can be a time for an audit or someone to question saying, hey, what's happening over here?
Yes. And it's interesting. I've seen some of these letters where they say, we look at item code, for example, 531. We've got statistics on the use in your suburb. We've got statistics on the use in your metro area. We've got statistics on the use in your state, and we've got stats in the country.
Yeah.
And they compare the profile of that practitioner to all those. The granularity of the data that they have is
amazing.
Scary.
It's scary. It is, and it also shows you that why in today's day and world there is no place to hide. If you're doing a good practice ethically, morally, and you're doing it correctly, there's nothing to be worried about.
Yeah.
I actually believe that the letter which gets sent to members, rather than taking it as an insult, you should also go, okay, hold on, because many times we fall into the trap. I personally have been that way. If I'm working in my room just by myself and I'm charging what I am charging, until the pattern actually shows up, which takes sometimes a year or two for it to ping up, and the health fund goes, or the Medicare goes, or even APRA as a regulator sometimes questions it and says, hey, can you show me your records for it? And they show an outlier based on the data. You don't know you're doing anything wrong, because no one has actually done it. So I prefer a shot above the bow telling me, hey, pull your socks up, rather than
what? Please explain.
Yes, please explain where it is. And many times you can actually explain, and they go, yep, actually this person is right. They're not doing anything wrong. It makes sense why they're doing it, and they go from there. So that's perfect example is a practitioner who didn't do a lot of cosmetic work or crown bridge work, was basically doing good preventive dentistry.
Yeah.
And that practitioner had a lot of item codes which were simple preventive dentistry which they were using. But hence on a large scale, those codes were what were being used the most. And when they were questioned in terms of it was easy to justify saying, hey, they're not doing anything else. They're doing only preventive work. They're doing fissure doing. So this is why, there is nothing wrong with that, even though it's an outlier, but it's actually justified. Yeah. And you need to have very good clinical records. You got to have photographs. You got to have notes for it. The old adage that an invoice alone is sufficient, it doesn't apply anymore. No. Even though the invoice
can help.
It helps because the invoice tells us that you have conducted a treatment.
Yes.
There is no, so that is invaluable fit for it.
Yeah.
So
Okay. Thanks. And I suppose we've talked a little bit about the what and the why. The next question is probably the who. Who might do an audit, and we have touched a little bit on that. So apart from, I suppose the obvious is the health funds, which are probably the most scary, and maybe Medicare Services Australia. Any other sources?
Yeah, I think it's important to realize that in dental, because the funding for dental, a lot of it comes from a third party, which is the health funds. That's why almost most of the audits are from a health fund perspective. It is becoming more and more common. I think members need to realize we're going to have to live with this because that is the way the world is going. As I mentioned, in medical fields where the funding is coming from the Medicare, they do the audits. They even path labs get audited. Radiology places get audited. In a dental perspective, our main fundings which are the CDBS, which is a Child Dental Benefit Scheme. In the past, we had the Chronic Disease Scheme, and the other person which can audit and which is going to become an issue as I see as time goes by. We've already seen a few inklings about it. Is APRA, the regulator, dental board, and these audits are actually a lot more serious when you have a Medicare and APRA audit, which happens. We are noticing factors, members, when they start using finances of like superannuation, some passionately super. As you know, those have long-standing effects. You will have a regulatory body who deals with that, questioning you, saying, has that been used in the correct manner?
That's a really good point.
And that's something we just need to be aware of, that as time goes by, there'll be more and more bodies who will be questioning us and using and asking us for it.
Yes.
If we are doing everything by the book correctly, there's nothing to be worried about. But these are the main bodies. I'd personally be a lot more worried about in today's day and world from a Medicare questioning, because Medicare, in dental, the amount is very low. So if a Medicare is questioning you, that means there's definitely a question mark, serious question mark. Another one which I've only seen a couple across Australia, but it can happen, is DVA.
Yes, and it's very rare. But yes, it can happen.
Yes, and that was another body which can question for its members. And those are a couple of the ones which, from the top of my head,
I think it's a really interesting point, and I think we're releasing another podcast about the compassionate release of suit. the entities that can potentially audit you there are the Australian Tax Office.
Yes.
Now, I would not want
An ATO.
an ATO question. APRA and also ASIC,
Yeah.
which is the Securities and Investment Commission. And there's
some serious ones.
some big, heavy-hitting bodies that you really don't want to be falling foul of. Yeah.
And many times, one things can lead to another. If sometimes you may have a health fund audit, and health fund audit which is basically an audit for the correct item code usage, but it has a financial link to it.
Yeah.
Those things can actually grow beyond a certain aspect, and it can actually become into and followed by an APRA audit or by even the state administrative tribunal audit. I've seen those who apply at stages.
Yeah. And sometimes health funds can refer matters to other bodies as well.
Yes.
If there are things that pop up in an audit, maybe unprofessional behavior or other things like that as well. As you said, things can grow
over there. Yes, we're very conscious of the fact that our members almost do all the right things.
Yes,
those are the type of aspects we try to make sure that it's dealt with. Most health funds understand, and they stay within the limits of asking about the item code usage. But yes, these things can grow.
Yeah, and we alluded a little bit early to what an audit might look like, and I think for many of the members who call us at Dental Protection, and probably you at ADA in your role, I think it's very distressing, and understandably so for members. The letters are often quite legally worded because they cite the code rules or the legislation in certain aspects as well of how their entitlement to audit.
Yeah.
So it comes across as quite heavy hitting, and maybe even we do find that some of the wording of the health funds can come across almost as accusatory, almost as guilty until proven innocent, or that's the way it can come across.
Totally.
And what is that your experience as well?
I agree, Colm. One of the things which I've always said is, we are very quick when you're opening a practice to sign up with a lot of the health funds. I would always say a bit of word of caution. The word preferred provider is a misnomer. I've said that openly, and I'm happy to say that from a risk factor basis, because a lot of practitioners, they fall into the trap very quickly where they sign up to be a preferred provider.
Yeah.
They have to work within a certain financial limit. Sometimes that can then lead to them using more item numbers than they would generally use. And that is where this thing can fall over, become padding on the systems. A high caps contract, that's another one, which is they have to be very conscious about it, that they read it very carefully before they sign it.
Yes.
I'm not a lawyer. I'm not allowed to give any legal advice at this stage, but I would say definitely get a lot of these factors looked at.
Yes.
Biggest question with an item code usage is, remember, and it's truly, I as a thing, if I get something, I'm going, what gives them the right to question us?
Yes. That's often the first question we get asked.
Yes. Do they actually have a right to ask me for my records? It's because you sign these contracts that they actually have the legal entity or factor to go from there.
Yes.
There is a question in this situation that a lot of the high caps are linked to the bank accounts through NAB and Commonwealth, and those are factors which then we need to, which they actually have an understanding between them for sharing this data. Again, I'm not a lawyer. I can't comment on these factors, but what I would say is that be conscious of the fact before you put your pen to paper. When the high caps machine which is being used, it gives tremendous data to health funds.
Yes.
Any other person who's been using this. PRODA will give enough information to DVAs, Medicare. So all this data analysis which is happening is keeping a track on how we are doing a billing and item code usage.
Yeah. And it's a really good point. It certainly really surprised me when I started this role. We've got a high caps machine in our practice. I think vast majority of practices do.
Yep.
But in the high caps contract is they have the right, the fund has the right to request your records, not only based on health fund rules, but also on high caps contract.
Yeah. And many times I tell people this. I say your relationship with your patient and you have, so it's a three-way relationship. Your relationship with your patient relationship with you, but patient also has a relationship with the insurance company, and the insurance company has a relationship with you. So, you have to keep those very clear. Sometimes the lines can get blurred. When someone is asking you a question, it's because that particular patient is also a member of that particular health insurer. So, and that's the right which they have to ask from. They're saying, is those funds which are being used, is they being utilized properly? Which as I say, 99.5%, it is. Most people do ethical moral practice, but there are outliers.
Yes. And I'm going to circle back to a really good point you made as well about preferred providers. Something else that I discovered in this role is that the health fund rules, there are pages and pages of them, and quite onerous, and some of it quite legally written, but we have a lot of obligations in the standard health fund rules once we engage.
Yes.
But if you're a preferred provider, there is then another layer of special rules for the preferred providers that are even more onerous in certain ways. You sign a deal with the fund for so-called preferred treatment, but there's no such thing as a free lunch.
No, there isn't.
You are more restricted as well in
And I feel really sorry for members in those sometimes situations where we have signed up for the preferred provider, but certain things are locked you in. And I've genuine case, certain health funds will cover a certain amount for, say, a mouth guard, and because you're a preferred provider, you're locked in to charge only that code for the but the lab fee for the mouth guard is a lot more. Now, if you end up making a mouth guard which is actually for that certain amount, and it's not for the purpose, it's not a 3-layered mouth guard for a patient, for someone who's doing a boxing practice and they get a trauma, who's responsible? The onus comes back to the dentist. And I think this is where it's very clear that this is taken to the health funds to be explained. As a practitioner, you got to have these discussions with your when you're signing these documents. Reach out to your ADA local branch before you sign these documents. Let them have a look at it. Get some legal advice before you sign your high caps documents. But there is a lot of obligations which are inherent on practice owners and practitioners. So there's no two ways about it, and we have to read the fine print.
So the letter or the email lands on the desk, and as I said, most members feel that there is an understandable sense of anxiety about it. There's usually a lot of them start off not by an actual audit where somebody comes out to your practice. Most of them are what we would call a desk, some form of either that very initial please explain, or the pointing out you're an outlier and just look at. We're just flagging up that we might see this. The next tier is maybe a please explain something small. The next tier is often a request for 1 or 2 sets of, or maybe a small bunch of records. Now,
Colm, you're right about this. I think the first step, which is I think is the best way, is when you get a shot about the bow, as we said. You get a letter saying, hey, your numbers compared to the data, whether in your own suburb or across, are actually much higher. Generally, if you deal with that, or you actually take that on board and you have a look, as I said, if sometimes you just don't know you're doing it, and you alter your treatment accordingly, or pattern or item code pattern, sometimes you may not be doing anything wrong and you can continue doing it. But being ready then that if you then get questioned, you're able to justify that and show that. That's the first, I think, is the nicest way with those people who do it. Health funds, Medicare will question it. The second one is, yes, they will then send a letter. Some health funds will not do that. They will straight away send a letter and say, hey, send us information on these 10 patients of yours, and a small cohort, they might say, in terms of it. Those ones will basically, when you get, it's actually a very good chance for the member to send back a lot of the information back to them with every single data that's in there when the health fund audit happens. The problem is when you get that letter, it's understandable. You get shocked, you're upset, you feel hurtful. On top of that, the most common thing is you're a clinician. You're spending your whole day doing a clinical activity. Your family to go home to, your balance. If you're a practice owner, on top of that, and you're balancing your staff and your admin and everything else, the last thing you want is this piece of letter which you have to respond to, and it's stressful. It takes time out of it, and that is where a lot of these factors come into it. I get it. I feel it myself as a practice owner. But and you said the wordings don't make it any better. And this is something which, as an ADA, we've been fighting with the health fund, saying, do not blame us or say you're guilty, until proven innocent. It's innocent until proven guilty. The tone of the letter many times puts you off.
That's a really good way of explaining. The tone is often.
Yes. And I've actually had this conversation with health funds quite a bit, saying if you ask politely, people would come forward. Their answer many times from the health fund is sometimes you ask politely, we're completely ignored, not even responded to for almost a minute.
Yes.
So I would say if a member actually gets a letter, treat it as a document which you have to respond to urgently. It's almost like a patient asking you for a request for record, you're giving a treatment plan. So try to get the information out as quickly as possible in a timely manner and give them all the information rather than bits and pieces. When I say all, be conscious of the fact in support of that specific item code.
Yes.
If you give them the clinical notes for the item code, give them the clinical pictures, give them the records, give them the models, rather than bits and pieces. Because many times, if you can persuade them that in those 10 patients that you've done everything correctly, 80% of the time, nothing to hide. The audit, the person just goes, this is right. It's just even though there's a variation normal, they'll put a note beside your thing that if this keeps coming up, they just let it go. But if there's a question mark or information is not sufficient to support the particular item code usage, they will then turn around and say, hey, we need to see a bit more data. And perhaps we could come into the practice and do a desktop audit. Now, it's a member's right. So someone coming into your practice is a big thing. You have to give up your practice time. You got to go and do it. You have a right to say no. You have a right to say, look, I'll send you all the information that you want, but I don't really want you walking into my practice. And, sometimes it does throw the factor that somebody might go, what are they hiding? Why don't they want me to come? But many times a practitioner might be a very big practice. They just don't have the energy or time, or they don't want the staff to be, questioning who are these people coming in. It does give a bit of indication, a bit of embarrassment is what we, as a practitioner, you feel as to do it. The truth is you have, as I said, you've done nothing wrong. It's an added headache, which you got to deal with. But on the factor that if they are coming into your practice to do it, make sure you treat them with respect. They are doing a job too. At this stage, let them come in. I would say it'll be very, very important that the practice owner is the one who's actually, or the person who against whom the audit is actually the one dealing with this when they come into the practice.
I agree.
Please make sure that you, only show them your patients and related to that particular audit. If they are coming from a specific health fund, not randomly going into others. There's a privacy breach there. You also got to be, it's good to be spending that time rather than having a youngest reception of the practice dealing with it.
They
will generally send you information before saying we need this data. Having those models, if they're asking for an 071 physical models to be present, having the models ready, having the lab slips ready, just saves a lot of time and headache. From there, again, if all of the information is given and it's very clear that what you're doing is very clear, there's no breach in there, most time audits go away. Where it raises red flags or becomes an issue is where somebody has written over there in the clinical notes very clearly saying, I'm going to bill for this bridge. I've done the prep now, bridge will be built in the new year. And you've done the bridge preparation on 31st of December. There is no going back from those factors about that.
And again, this is one of the classics. The health funds are very live to that one. Do we have a right to say, no, you can't come? Or if push comes to shove, as far as I know, they can come eventually.
I have actually recently looked into this, and from a legal perspective, you can actually have a right to say no. And then do not walk into your practice. I will, obviously, I'm not a lawyer. I will re-clarify that. But in one of the most recent audits where I have had, the member has got legal advice and was able to turn around and say, I prefer not for you to come into the practice, but I'm more than happy to send you all the information that you need. And if despite that, you would still like to come in, we can have a chat about it. So they provided all the information. They actually took a carload of models and dropped it off for there, and you do have that option to do there. I think if push came to shove, the auditor does, especially if it's a Medicare audit or an ATO, there's no way you could stop that from coming into practice.
And I think so a few points. I suppose if you get that initial correspondence, while we don't like that legal wording, the fund should cite the code number, the Section 4C, subsection 2 is our right to request these 10 records. I think probably if the practitioner is unsure, they shouldn't release records. They should contact their indemnifier or ADA experts in the,
Totally agree, Colm. I think when this happens, the first thing the practitioner should realize is they're not alone.
Yeah.
That's the first step.
Yes.
They do not have to go through this ordeal alone.
Yes.
That's why they have DPL, ADAWA. We have, DPL as a dental legal advisor.
Yes.
They reach out to them, reach out to your local ADAWA branch. Even if you're not a DPL member or ADA member, you reach out. But the most important point we want is that, remember that you're not alone in this particular factor. It may feel very lonely.
Yes.
When we get these audits, even as an ADA, when I get it through, my first step is I also reach out to DPL to say, hey, this audit has come through. We work as a team to support the member. It's not a one-off factor there.
Yeah.
The other important bit in this whole picture is that if you're not, as you mentioned, unsure as to what record should I release and what information should be given, first send it to your local branch or your DPL member and get them to have a look at it. You can write back to the health fund very clearly saying, hey, I am taking the help of my local profession. Please let this be dealt with. At your local level, your CEO will help you. DPL members will help you. We can look it up for you, give you a bit of information, and that is the information that you can then use to do it. So biggest point when I have this, like anything else, if I get into a little bit of thing, I just want to know my local members are there to help me out. My profession is there. It doesn't mean that there's a judgment call being made either way if you're having an audit. So please do not be afraid that premiums are going to go up just because you're getting an audit being done for that. Please reach out.
I agree with that.
Yeah.
And often we can identify pretty quickly what the subject, even though it's not written in the...
Very good point, Colm.
We often...
Very, very good point. I think one of the biggest things is members want to know why are they being audited? Like, why me? And where does it come from? And because of the extensive experience that you and your team have, Colm, and ADA member, the peer advisors and other have, they can very quickly look at what of these and do it. Most of the time, health funds do specify when they write the letter saying, hey, we have noticed a particular factor in there.
They do.
And they will then ask you to question, but not in the first letter. So that's why at that point of time, if you reach out, we can, and that's a very good point, Colm, that and it helps clarify for the member also as to why am I being audited for that.
And I suppose that we've covered that first call, first contact. Anything else, I suppose, to add to that? Other than the overarching thing is it does feel very threatening. And I think we get that completely. How it could be perceived threatening to the individual, my registration, my reputation, my business, all these things, my relationship with the health fund, because in particularly in WA, there's one fund has a particularly strong market share and all those things, and you don't want to fall foul of that or of all of those things.
And that's a very good point, Colm. I think the important, you mentioned very commonly, members always worried about the fact that if I do push back, the health fund is going to deregister me, this is going to happen. The truth is, standing up for yourself, explaining what you've done, there is nothing wrong. Sometimes we fall into traps which we do not know about. We may have variations which we are not aware of. The rules are changing on a day-to-day basis. The onus is completely on us. If we stand up for it, and many times if we have done a mistake and we admit it's a mistake, most health funds will look at it from a factor that, don't do this again, let's move on from here. And, there may be amount which may have to be refunded to the health fund. But that doesn't make you guilty of any fact. That's the difference what you're trying to say over here.
It's sort of a reconciliation.
Reconciliation or something, they realize, okay, this is what has happened. Somebody might have been given bad advice in certain ways. They may have not asked the item code committee for a particular advice, but asked another colleague who may have been practicing a certain way in certain manner for a long time, and they probably fall into the traps. I find a lot of that, especially with new graduates and even with internationally trained graduates. Very common with ADC graduates also who come and start working for...
Because we don't know the system. We're both international graduates. We've come and we don't
start here. And, despite the book being a very colorful book, the ADA item code schedule book, Yes, it is quite dense.
Yeah.
One tip which I'd give people probably in this situation is please read the book, especially the notes for guidance, which is from page 7 to page 17. It gives you a lot of examples, gives you a lot of information.
That's excellent advice. I think that is excellent advice to read that book.
Read the book, because a lot of the answers which you're looking for will be in there.
Yeah.
I have had members asking questions saying, hey, before if the patient is sitting in the chair and I need to know which item code to use, what do I do? I've actually had members call up during that time when the patient in the chair to ADA and ask, and they get the answer almost instantly.
Yeah.
But you have options where now they're using PEER, which is an ADA federal protocol. You can write an email. Many times within the first 24 to 72 hours, and if it's a big information, it's provided back to members. So you get quite a bit of support from your professional association. What is more important is do not ignore it. If you get an audit and you have to deal with it, number one, do not delegate it to your member of staff to say you respond on my behalf, because the audit is against you all. Many times an audit is specific to the particular practitioner. So the practitioner may or may not be the practice owner at that particular situation. And sometimes the practitioner may have even left the practice. So the common question we get asked is, hey, we've got this audit letter to our practice against this practitioner, and this practitioner isn't here. Let your health fund know that this medical practitioner isn't here. But at that point of time, you may also have to provide those records to that practitioner during the time they worked here, so they could then use it to support their use of the item codes over there. So that's some bits I would say as a guidance rule. Deal with it. As a practice owner, do it yourself. I know it takes a bit of time out of your life. I know it's very frustrating when you finish work at 6:37 in the evening. You want to go. I have a young family. I'm rushing to go back home, but I have to deal with all these bits and pieces. And more importantly, if it's a practice where the whole practice is being audited, support each other. The youngest member or the practice might be feeling really left out, and they've just come into it. So
really scared.
Scared about it. Help each other out. Be there for each other. And reach out again to your ADA, reach out to DPLA. We will help you. They're there for that.
Yeah. I think that's an excellent point. And I suppose a request from us would be, don't do the tempting human reaction of burying your head in the sand and then calling us the evening of the deadline of the day before you're supposed to submit all this.
Oh yes.
Please give us time to work with you, because often these things can be quite complex, and there's a lot of. I know you spend hours and hours on your weekends giving up your time going through records. It's very, very time consuming to really do an analysis of these audits to help members.
It does. You do it for the sake that you're all in one profession. You want to do the right thing to maintain the reputation of the profession. And same with DPLA is doing so much effort for it. So please, if there is sufficient time, without feeling, and I know people go through the whole phase of first ignoring it, and the anger about it. You go out those phases, and sometimes those phases takes time till you accept that I have to respond because there is no other way. It's not a bad idea that when you get this letter to first of all, realize an audit doesn't mean that you've done something wrong. You're not guilty of anything. Take it as another question mark. Someone is questioning it. It's like when you're a dental student, you're asked to justify your treatment plan. That's pretty much where it's coming from. You then use that information, reach out to supporting members, get the information out there in the right format, send it back through. Many times that's the end of the matter.
Okay, that's a really good point. One last question about how an audit might happen. And this is something we get regularly asked is, can the practitioners ask, and I can see the reason why they ask, they say, why can't I send my patient into HBF and so they can see that the bridge is good or the filling is done? I've never heard of that happening. Most 99% of the reviews are desktop. The health fund will never call a patient into evidence. It might be a thing of very much last resort. So, but it is a question we get asked a lot.
So you're totally correct. First of all, I'll go back one step. You just said, what are the rules or what are the pillars on which any, especially health funds or Medicare, are using these audits? You have the code of conduct, which is definitely what is by the Dental Board's code of conducts 8.3. Helping records. You have the ADA's policy on record record keeping. You have the high caps which you signed. And those are some of the legal entities that the health fund uses to stand on to ask for the audit information.
And your health fund contracts,
which you've signed for it. If you're a preferred provider, that has another level of contract where you have to oblige for it. And you're right. And many times, if I'm a basic practitioner and I've forgotten to write my notes, and look, this happens to all of us. There is no practitioner out here, I believe, who
absolutely
not written note. But if they have, and sometimes you've done an X-ray, for example, a 022, and you've not written note for it, but if health fund asks for it, you have an X-ray to prove. You can just turn around and do it. And I know that's a question which sometimes we get. They say, hey, you billed for a crown, but there is no, notes for the crown. And obviously, you may not have taken a post-op X-ray for the crown insert. And the health fund wants to know if there's no notes for it, but you're billed for it, and they want to know for it. Many times you may have a lab slip. And then unfortunately, if you don't even have the lab slip, because you might say, hey, I've used a CEREC crown and you've milled it, you could use even the CEREC design which you have with the as a factor, as evidence to support your CEREC crown. There's nothing wrong in that. All of this acts as evidence to just say, hey, I've done it. Especially and that's why keeping good clinical records is very important. But if you didn't have any of that and you had the photographs or the X-rays or the digital scans to show any of those pictures, you can still support it. The problem which health funds, they do not want you to get the patient involved is because it leads to a reputational damage for them.
Okay. I hadn't thought of that. But yes, that makes sense.
It actually, and they do not actually want you to reach out to the patient saying, hey, I'm being audited for this particular purpose. I would like you to go, because that then destroys the relationship. As I told you, it's a three-way relationship. It's a relationship between you and the patient.
That's interesting. I never thought of that.
But interestingly, it also has it in the contracts and reading the fine print that it says reaching out to the patient is a no-no. This is a between. So that's why I said, those fine prints, have a look at it and see what it is. So when you start reaching out to the patient, it's then that breach of that particular contract, and that's where the health funds do get a bit upset, saying, hey, this is us deciding on this. How can you reach out? Now, if for whatever factor the patient did come in during that time for the 6 monthly and you took an X-ray or took a picture and you proved it with that, no big deal. There's no issues about it over there. So nothing stopping from that aspect. But if you reach out to them or especially if you send an email out or you send something else, then those can lead to some legal issues. Over there.
Okay, that's interesting. I did not know that.
Just for information's sake over there. So, but I have found that is a big thing that health funds are not very keen for you to reach out to members saying, I'm being audited for this particular past. And as an ADA, we have fought very clearly to say our relationship is with the member. We have a relationship with the health fund through your high caps, but we have a direct relationship with the member. So if a member has a complaint, we'll deal with it directly. But when it comes through this factor, yes, I have to deal with you and that aspect. But the question which you're asking is spot on. Why isn't the insurance company directly reaching out to the member and bringing them in to have an examination or have a look for the patient in that particular aspect over there? That is a very good question.
Okay. Now, we talked earlier about the benchmarks used by the funds or the entity like Medicare. It might be worthwhile just stepping through a few little points and tips or things to look out for on each. Probably the most obvious one is as you've mentioned, the fund rules or use of high caps. What do we need to consider here in terms of fund rules? I think the most obvious one is that unfortunately for us doing this, each fund has slightly different rules.
Totally. I wish, and this is my personal wish. I do not say that. I wish we could get all the health funds to sit down and actually work out rules which would be standardized and be used across the board. The worst ones are where some health funds are telling you bill the crown at the prep, bill the crown, and other health funds are telling you bill the crown at the insert. The poor dentist is doing the prep and they're so stressed out about now, do I bill it at the start or the end over there?
I know.
The truth is, the ADA schedule tells you that in a multi-unit appointment or a multi-visit appointment, you can bill at any point of time. That is, when I say any point of time of doing the procedure. You can't consult the patient or the day of the consult, bill it out for the crown. It's during the procedure. Means when you did the prep or you did the try-on or you did the insert. That's what the ADA schedule tells you. So the 4 pillars which I told you where health funds will turn around and tell you that, hey, the ADA guide tells us that you have to bill it at the prep is wrong. So those are some of the common ones things where sometimes health funds do get it wrong. And I say that with tongue in cheek, but you have to. That's the reason. Knowing your schedule in and out, knowing your guidelines, asking the AD item code committee for clarification for certain item numbers, reading the FAQs that are being sent out are very useful. But an important point in these situations are many health funds do understand if they see that you have had a pattern of billing your crowns always the prep. They will understand that completely. It's not that they will turn on and say, they'll say the fund rule is that you should bill it at the thing and you've signed for it, but it's not like they will question you. Where it becomes an issue is if you're used to billing it at the start for all your patients, but then on 31st of December, you decide to bill them all on the 1st of January, there is a question mark that gets raised over this.
I think that's a really good clarification on that. So probably, I suppose the rule of thumb here is then be consistent within the boundaries of good behavior, standard behavior.
Standard behavior. The protocols that you have been doing. So what common other ones are if you're making an occlusal split. I know practitioners who have actually done a full occlusion analysis. They have the document. They've charged a 963 code for it. And when I say full occlusion analysis, they have to look at the muscle assessment, the bite assessment, the TMJ assessment, and they have to write on all of those.
I've done
for it. Some people actually have a full form on it. I know for a fact. An oral medicine specialist takes an hour sometimes to do that whole occlusion assessment. So it does take a lot of in-depth understanding. Then if you're charging a 963 based on that and a 965 for your splint, which you're charging for it, it's justified. But if you are charging a 963 and a 965 with nothing to support it, it becomes a problem. Similarly, a lot of general dentists, orthodontists who do aligners, many times the code, and it specifies here, is all encompassing. Means when you're doing aligners, the 825 code encompasses the attachments, the buttons which you're putting onto the, it encompasses the IPR or the interproximal reduction which you're doing for it. You do not have a separate code for that. The number of times we get questions saying, hey, can I charge a separate code for it? If I'm putting a composite button, can I charge 521? But that's a restoration. This isn't a restoration. So sometimes you know the answer also, but it's where you're questioning it. Should I? Shouldn't I? Maybe
you're being told by a principal or someone, supplier.
Yes. And as sometimes as a practitioner, you do not know. At those type of times, pause, get a clarification in writing from your item code schedule committee in writing, and then you have that as evidence proof, because once it's there in writing, it helps you out for whatever purpose you need to use it for. So I would say that's a very important point for risk mitigation practitioners, especially younger practitioners, new practitioners, or you're starting something new and you're not too sure what code to use. Perfect example, this morning before the webinar, we got a query on what codes should we be using for a microabrasion, and it's not a commonly used code for that purpose, and it's not a code that many members use for it. So 116 and 163, just for information's sake, are used, and the member wanted to know, well, I'm doing the microabrasion, that's your 116, and the 163 is resin infiltration, but could I also charge a 521, which is the composite, because the resin is pretty much the bond, in terms of it over there, and look, the member has a very good thought process from it, but the code says the 160 with resin infiltration is all encompassing. There is no separate code, and that's where we have to be also careful, because in this particular situation, the member was using the software which cannot show you the full description of the code on your software, whether it's Practica, whether it's Dent for Windows, whether it's Exact. So many times, if you do not go based on what's just given by the partial description, use your schedule. You can download a PDF copy, keep it on your desktop, jump onto it, use the search button, and that'll help clarify and sometimes, prevent a lot of issues from happening.
And something that I think you said is really important as well, and I just want to re-emphasize this, because this could save a lot of grief. If you go to a course or you buy a new piece of equipment and a rep or the company says you can bill this code, question it if you're not sure. Get it in writing from that person. Don't do anything without it in writing, particularly if you're doing something new or something different or something that you've never heard of before.
Yes.
And or check it with.
Yes. Very common. A few examples, and this can be even sometimes the speaker, sometimes saying a particular code which they're not sure of, or they might say, we have been doing this. And just because someone has been doing something for a long time isn't necessary. We are taught in dentistry to question everything that we do. We are taught in dentistry with evidence-based factors.
Correct.
So, I would say you apply that same aspects for it. Make sure there is sufficient evidence from the people who are actually writing this book, from the item code schedule, that this code is justified for that particular purpose. Many times, we also have to be careful. I've been asked this question saying a lot of codes are very vague. They're not very specific. And that's because if you start making it very specific, the book is going to be, 200 pages. So it's outcome based. A lot of these codes are outcome based, and that's how the treatment works for it. For example, if you're using a bond as a desensitizer, then that's a purpose for it. You can be using it as a sealant in that particular aspect, or you might be using the bond as part of your composite. So the same bond is being in two different purposes, but it's a different aspect for it. So you have to you code accordingly. Those are some of the factors which I'd say be conscious with. And as you said, Colm, one of the simple examples, if I might just mention for the webinar's sake, is there used to be a company which was selling, and I think it was in the past, where they used to sell topical fluoride or prophy paste which had a bit of fluoride in it. And the company which was selling it said you can charge it as a 1-to-1 because it's a prophy paste with fluoride in it. But it's not the case, because the function of topical fluoride is specific to a particular area. You'd apply the prophy paste and wash it all off and rinse it all off. How is it actually staying in contact with the tooth surface to give it from there? So that is one example. In the recent ages, 041 has been another very common code that has been used. A simple plaque disclosing agent cannot be built out as a 041. You just have to be conscious of those particular ones, despite sometimes what you might want to know from a company. And very commonly, members ask this, and I feel for them. And the argument is, hey, I've just spent 35,000 on a new scanner.
Yes.
Why can't I charge a 071 for a new, for taking a digital scan? Why isn't there a code for a digital scan? The argument is you could do that same impression with your $5 alginate with a tray. So were you charging for the alginate impression? If you're not charging for the alginate impression, how are you charging for the digital scan? You can charge for the study model that you produce from it.
Correct.
We are moving.
So it's the outcome.
It's outcome based. You can charge the digital wax up, which you might get, again, is an outcome based. There's a code for that. You can charge for digital modeling, which is another code for that, the 075s and the 076s. These are the digital modelings and the aspects from there. But to charge for just because you got a digit spent on a piece of equipment, using that as an ROI to charge an item code is not where it comes from.
Yeah, I think it's a really good explanation of that. Another aspect of variation that can occur in fund rules, and we do see people falling foul of it occasionally, is treating family, co-workers, the boundaries, and I think each fund seems to have slightly different rules and variations on that.
Yeah, my best advice on that is, and I've had this where I totally agree with the member. I've had members go, look, I have an autistic child. I've been treating my child. That my child is not going to go to anyone else. I'm not doing anything wrong. I'm billing the pattern correctly. Just because the health fund tells me I can't treat my child, what is that? And I could claim for it. But my child is paying the money for the insurance, and what is wrong in that one? I totally get it.
I get it.
I don't disagree. And in many times in this sort of situation, and this is a true example where we actually reached out to the health fund and said, this is the situation. And the health fund has said, totally agree with you. And they actually just put a note against your name, and you can do it. So sometimes you question the health fund and say, hey, I am treating my family member. This is what I'm doing for them.
to a set
of circumstances with it. The reason why health funds get a bit worried about treating family members is that they have seen, again, we talked about this in the start, where there's been patterns where on the last week of December, you will have 6 members of the same family all having splints or night guards or things, it's pretty clear what's happening in those situations, and that's where the health funds are going. It's not meant for maximizing or getting the maximum money out of if it's a necessary and there's a need, then definitely. Now, on the counter argument, if a family's been having their check and cleans every year, because many times dentists have argued, hey, we are so busy the whole year, we have no time to treat our family.
Yes.
They're coming only around Christmas time to get their check and clean. Yes. Is that wrong? No. If you have all the evidence to show what it is, yes, if it's a health fund rule, you have to comply by it. But there's nothing wrong in you touching base with the health fund saying, hey, this is what I'm doing. This is what it is. If you'd like me to pre-send you the treatment plan for what I'm planning to do, I don't, there is a aspect of application where you're doing the right thing by your. Yeah.
And one last thing in terms of fund rules is rebate only. We get asked questions about as well. It can be a little bit of a gray area sometimes.
It's a very good question, and without saying too much, look, practices that practice only on rebate only fall into traps of padding their item codes.
Okay.
That is where the biggest issue lies.
Yeah.
So, because if a practice is going to go, hey, this is what I need from an hourly basis, and I'm going to be charging these 6 item codes for the hourly basis, are those 6 item codes actually necessary?
Yeah. So it's a check and a clean, and suddenly six item codes
come as part of it, because they have to reach a certain thing. And that is where then it pushes that algorithm we talked about, health funds realizing what it is. Rebate only by itself is not legally wrong.
Yeah.
Reason behind it is, as you've seen, a lot of health funds themselves are saying, hey, gap-free dentistry, come and have your check and clean.
Yeah.
They have their own practices which are offering that's effectively rebate only.
Yeah.
The truth is, even in the medical world, you have practices which are, when you go into a medical facility where they go, this is a bulk bill practice. A bulk bill practice is you're charging the Medicare for it.
Yeah.
So, technically, a rebate-only practice is not wrong when you're rebate-only. But if you're running your whole practice on a rebate-only policy, there is issues over there.
There might be aspects of the business model
that might be affecting, because then you're either over-servicing the patient, and that's a risk factor.
Yeah.
Or you are using item codes which you haven't actually done on the patient.
Yeah. Upholding.
And this is where we talk about an ethical moral practice. The biggest thing is you want to risk mitigate. You want to reduce the risk factors out there. If you're doing a check and clean, you're doing a check and clean. If you're using a fluoride, you're doing it. Many practices have a policy where they actually write in the first examination, patient is a high-risk patient or a moderate risk or low risk. And the high-risk patients get the fluoride every 6 months.
Yeah.
And the low-risk patient might get it once a year.
And clinically justifiable.
And it's there for it. They're able to show x-rays to show where the caries are there. But if you have none of those, and you just say fluoride only and leave it as that, and every single patient in your practice is getting it, there is a questionable doubt or question by the thing saying, is this really necessary treatment? And those are the factors. Truth is, it may be necessary. Yes. Maybe you're working in a suburb where the patients do not have fluoride in the water, and and those happens in WA. There are a lot of those aspects were there. So there's nothing wrong in that.
Yeah.
But these are the way.
Again, all that clinically justifiable, or if you do get questioned, if you're an outlier, having the justification, your particular context or set of circumstances
can make a difference. Yeah.
And having it evidenced in the records again.
Correct. Yeah. Records. I can't reinforce that enough, but records doesn't mean it's a group of documents. It means from your invoice, to your treatment plan, to I even tell people, I say, even if you scribble on a piece of paper, I learned this from a prosthodontist. If you scribble on a piece of paper, you'll use the piece of paper, and then after that, you actually put that piece of paper as a scanned document or a photograph of it. You date tag it, because it gives you information that you've actually explained to the patient. You may have drawn a root canal or a tooth perforation and at part of time to explain to your patient. But just keeping that picture in your document. Today's day in the world, it's so much more easier with a scanned fold document. Makes a lot of information.
CDBS, anything? I think I always worry about CDBS because there is a compliance thing. You got to have the consent forms, and that worries me a lot about CDBS.
People think CDBS is a lot easier. It isn't. You have to read the CDBS rules. A lot of treatment plans have to be pre-approved.
Yeah.
There are situations where you can't charge multi-surface restorations on the same day. There are situations where when I say can't charge, if a patient needs it, you approve it, you get it written up and you do it. But if you've just gone ahead and done it and you get questioned, then people get worried that, oh, why am I being questioned? But there's certain rules with Medicare and CDBS, especially with any Medicare concepts. Today it's CDBS. It used to be the voucher system. It used to be the chronic disease system. Please read the rules very carefully because CDBS audits may take years later to come. But they can come.
Yes,
definitely. So I agree with you. I think CDBS and any of these pre-reading the rules correctly, I know it's a lot of reading which a practice owner has to do, or the practice practitioner who's signing off on it has to do. But it's very necessary to get those in place. So another one which is a common one is consent. Yes. It's not specific to the correct item codes usage. But where the consent does come into place as part of the item code usage is that you have actually explained to the patient, hey, I'm going to be doing this, and this treatment on you. This is the particular treatment plan in which there is already the item codes being quoted to the patient. The patient is aware of what the fund is covering, what the gap is, and that's been actually then put through. When you actually even present a treatment plan to a particular patient, it actually goes through your software. And that actually acts as a record or a proof for the purpose of if ever an audit happens over there. So there's nothing wrong in showing that. Plans change. Perfect example, you go in for a patient, you're going to do a crown prep, you open it up, you find a crack there, you've estimated them to give them a crown, and yet when you open it up and you notice a crack and you might decide to put a foundation and put a provisional crown over there, which you might say, I'm going to leave it for a period of 3 to 6 months to see how this gets restored. The provisional crown wasn't actually given as a treatment estimate before, but you have a picture in your clinical showing the crack, the discussion that you've done, the records that have been put into it, the provisional crown has been built to it. There's nothing stopping you. You're fully justified. The problem does happen sometimes is where you've done the provisional crown and literally a month later you might do a permanent crown, where the health fund might then question you saying, hey, the provisional crown is supposed to be part of the permanent crown, but at that point of time, for whichever reason, the member may have said, the patient would have said, hey, I'm traveling today, my tooth is all really good. At this stage, I do want the crown. You have told them that, look, I put a provisional crown at this point of time. It's better to wait and watch. You've documented it, the consent and the refusal of following instructions and going with the final treatment. That's all evidence and proof for it.
We've talked a little bit about the schedule and glossary, and I think this is certainly your area of expertise. We have what I call the low-hanging fruit, the 114s, the 022s, the 071s. Do we need, like the 022, I think is a really good example of what you've said, what shows up on your software screen versus what's actually written in the glossary.
Correct.
Do you want to elaborate on that? Where I think often fall foul on the 022 or the 114, very similar to the 07.
I totally agree. I think when we have actually even worked with the health funds to see what are the most common audited numbers over the years, we do get told the most common ones are what 071s, and part of the reason is that especially with the advent of digital dentistry, which I totally agree with. If you're doing a digital scan, and if you're using that as a work in place of producing, say, a crown, or it's being part of a working model, then the 071 doesn't apply. But if you're using it as a study model and you actually have the notes to say what the study model was for, with justifying what did you actually find, the diagnosis from it, and now sometimes the argument is, well, I've done the scan now, I need to come back later and study it and write it. That's fine. You have a date tag later saying, study model studied, this information given, shift to the right hand side, shift to the left hand side, class 1 malocclusion, whichever way you have. And what is the purpose it took a patient, severe wound patient? The plan is to do a comprehensive mouth rehab in the future. Study model is being done now to analyze all of this. It's justified. But if you're charging an 071 today and the next appointment you charge out a splint or a mouth guard, there is a hard way of justifying for as an item code usage as to what it was. Unless you can actually say that model was duplicated, you have one set as a study model and one set as a working model, and that working model is then being used for the splint. And the argument I've had in this situation is, in today's world with a 3D printer, you could be printing 2 sets of models. modules.
Yes.
And you could be giving one set as a working model and keeping one set for it. Yes, if you have done that and you actually have your findings in the study model and you said why the study model is necessary for this particular treatment plan, but those are the common ones we get. Problems is people will sometimes scan only a small quadrant or a small section and charge 071. That doesn't stand in the court of law. We have even had ones where members have actually charged for a 965 splint. It's a very common one where they would actually give out post orthodontic treatment. They've filled up the orthodontic quota and they want to actually give them retainers, but there's no rebate on the retainers left, so they'll actually charge a splint. And those are things where people fall short. If you're doing a splint is a splint. You cannot use a splint there to do it as a bleaching tray or things over there. There are codes for that. Common ones which people fall short, as I said, 022 with an X-rays. It's the key word which the book tells you is an intraoral taking of an X-ray. You are also, it's the interpretation of the X-ray, and it's also the diagnosis that you're making from it. So if you are taking an X-ray, just writing X-ray taken or PA taken, unfortunately, is not enough. And today's day and world, you actually have to write what are the findings from it. Because we are, as a dentist, we are a diagnostician and a clinician. And what is the diagnosis that you've got from that X-ray is important. You can write, people have a format sometimes. They'll write saying caries noted, the bone level present. They would write about defective restorations. They will write about what restorations are present in them. They might write about unerupted teeth in it. They might write about various of the findings, but it shows you've actually taken time to study the X-ray. People ask me, can I have a fast note for that? Nothing wrong in that. You can have a template if you have a fast note, but it is specific to that X-ray. What you see is what you write into it. So that applies not only to 022 but also to an 037. And that is where I think the difference also comes with the CBCT. In WA, other states are different, but in WA we got to have max fax radiologists reading it. To be honest, I believe we are not trained sufficiently to be able to find all the findings. So having a max fax radiologist looking at it over is very, very important. With all those findings.
I do happen to agree with that as well. You've mentioned the restoring implant access. Another one we see is 419 and 572, which can be done. But often in the circumstances that it is done is falling outside.
That's a good one. We actually have an example of that in the schedule and guidance book about an exact example of the 419 and the 572. Perfect way of saying it is, if you have a tooth which you've made the diagnosis, it's pulpulous and infected with a secondary chronic apical periodontitis or acute. Basically, you're going to start a root canal treatment on that or extirpate the pulp in that, which is a 419. You, at that point of time, the question is, well, the GIC would I put in the access chamber to close it? Why can't the charge be at the 572? That GIC which you're just doing to close the access chamber is an inherent part of the 419. But if you have investigated the tooth, which is where you've stripped all the fillings off over there, actually gone in and had a look and see if there's any cracks in it, see if the tooth is really restorable, removed it, made it caries free, and then rebuilt the tooth back up, you actually can charge for that. Whether it's a 572 or whether it's a 533 or a 534, depending on what material of choice you've used, it is justifiable. There's nothing wrong in it. Some people put an endo band and then there's a code for that, which is a 574, which can also be charged out over there. A common one with that one people ask me is, hey, I charged a 534, did the filling into it at that particular area, I spent time doing a big composite into it, and I did then a root canal treatment, and later now I'm going to do a crown, and now I'm charging a 627, a code, and then I'm doing a crown onto it. Are you using the old composite which you built up as a core? And if you are, then is the 627 justifiable? And the counter argument to that is that if that 534 has been left there for probably 6 months to a year, could have leakage underneath it. You need to strip it all off and replace it, in terms of it. Or strip and build a new foundation up. You're justified in doing it. Clinically justified. And again, if you have done that and you have pictures to show that sequence, for example, it's very useful in today's world with your digital cameras, with the intraoral pictures, with your scanners. There's so much information you can collect which can support what you're doing over there. So there's nothing wrong with that.
Okay. And the other one that comes up is we're trying to be conservative with teeth. We see an upper first molar with an MO, with a mesial caries and a distal caries, and I do a separate MO and a separate DO.
The ADA schedule actually is very big into prevention, and health funds accept that. If it's the same tooth and you've done 2 separate fillings, an MO and a DO, technically you can charge it as two separate fillings. You can charge it as 2 into 532s. The question comes down to this is where that gray line of ethical and moral practice comes into it. If you spend time and you've done it all together, the filling, the marginal ridge between them is very, very tarnished. Technically an MOD in there, is it a 533 or is it 2 into 532? Yeah. That's for the member, for themselves to ask. But on a prevention basis, if it's a big molar, you've done 2 small proximal boxes, minimally invasive, to get into those, and you charged it separately, that's fine. If you use 2 separate materials, yes, you can definitely charge a 512 and a 532. But why would you? Why would you do an amalgam on one or composite another? The argument also is, what if I do it on a buccal filling on the particular molar, and the buccal is a GIC and the occlusal is a composite or a DO composite in terms of it? Then what's the codes for that one? Again, are you going to come back with a GIC and replace it with the next 6 months? And did you put the GIC because it was quite curious in terms of it? Then that GIC is technically a 572. It's a temporary. Outcome based. So it comes back on that perspective. So prevention and outcome based for them.
And it's also how you can justify maybe charging the patient. You might have a bit of an argument with the patient who says, this is one tooth, why am I getting charged twice? That's another story.
But and that's why I said that comes down to the relationship with the patient and the dentist. Yeah. If you're able to talk to the patient and the patient goes, hey, you did just on that same tooth. Yeah. Why am I getting that question? There's definitely a question. That's why I said that that's where your the dentist-patient relationship is different, and from us health fund dentist relationship over there.
Yeah. And anything else from your years of experience in doing this that maybe comes up relating to the schedule?
I think the schedule, what I'd like to sort of say is, since I've been on the schedule committee, I haven't been there as long as a lot of other members, but what I've realized is they work very hard. It's a fluid document. They are always trying to upgrade and keep up with the latest technologies. But we are very careful if there is something that's a new fad, and just because it's a new fad and people are using it doesn't mean it's the normal way of treatment. So at that point of time, that's not something that becomes, hey, this is daily process. This is the new norm. You have to wait for that evidence to come through. You have to wait for a certain period of time. And I know members get frustrated as to why can't the schedule keep up with it. They are trying. In the just an example, in the next schedules as we go along, we are looking at changing each of a physical model, where to use the 071s as a digital model also, so that we have that purpose for it. Because that's a question members are asking in today's day and world, from an environment and a sustainable perspective, why would we print out thousands of models when we can produce the model if required?
And you can articulate them on the screen
and get the information. But yes, if you are using the information and studying it and writing it, so the schedule is a document that's based a lot on feedback. Members have a right to give back the feedback. The schedule will utilize that. I have seen item codes that have been removed from the schedule based on non-usage and then bringing it back into place. Where I would like to mention a very clear point, which since you asked for this, Colm, is the schedule doesn't determine the rebate or the insurances produced on that particular item code.
Yes.
It doesn't mean that usage of the item code is wrong if it doesn't have a amount indicated to it. But this is where it becomes very critical. Giving the example of the implant access code, where in the past members would use the 521 or a 531 with an implant crown or the 6-7 codes. Now the fact that it's an integral part of it, and later on if the patient comes back and uses a screw access chamber opening and closing, which is 692 code, there is no, health funds do not give any money on that. When some do, some don't. When questioned, the health fund's argument is, we have to wait for our data ourselves to see what money is being given back, so we can allot a certain amount to it. Now, members are going to tend to use going, hey, if there's no money being given back, should I use that code or not in there? Because the patient is being out of pocket. If I use a 521 or a 531, they are getting some money back on it. The financial drive should not be what should be the correct use of item code. You do the right thing. The member, if it's up to the member at that point of time, if they have a problem, they can go and raise it with the health fund saying, hey, why isn't this being refunded back in there? But if you use the right code and more members use the right code, then there is a very high likelihood that all health funds will come to the party and say, this is the most common codes being used. Perfect example, we had a whole series of denture codes where refunds were being given because in the past, a lot of dentures were being used for it.
Right.
And there was a lot of money has been given back to it because each and every section, whether it's a retainer or a clasp, everything had a certain itemized number which were being used over there.
Yes.
So that is what we got to think about. Do the right thing, use the right code for the right purpose, and don't worry about the rebate aspect of it. That shouldn't be the driving force behind it. And neither does the schedule committee have any say in what the health funds will rebate.
Yes, that's right. Yeah. So I think we've covered off on that really well. I don't think there's a whole lot more to say about the APRA Code of Conduct other than probably the main areas that can be referenced back in audits are the record keeping, so that the records, there's sufficient information to ensure continuity of care that outlines the specifics of the treatment, such as you said, the interpretation of the X-ray, or that you've actually removed calculus. It's described in the records when you claim a 114.
Yeah.
So tell the story of the treatment that you've done and referencing it back to how you've used the code. Sometimes unprofessional behavior can be raised as part of the code of conduct. For example, if there's something found in an audit that is considered unprofessional behavior, but anything else?
I think the other one, which very commonly one which you come across, is a lot of practitioners, very experienced practitioners, doing all the right things, but they've been doing it for 20 years.
Right.
And now suddenly, with the change in the record keeping guidelines, the factors that we have to keep more information in today's day and world, just writing SC scale clean, or writing a word saying FS fissure seal is insufficient record evidence in today's day and world as what it was 20 years ago. But your members are arguing, hey, it worked for me 20 years ago. Why isn't it working now? Because things have changed.
Yes.
And this is where I think keeping up to date, a lot of those members who are very experienced, very ethical, very moral, take things to heart when they go, hey, nothing has changed. No one actually told me this. Record keeping is another very common clinical assessment. It's another clinical skill. It's as good as you doing a very good crown prep. In today's day and world, that record keeping is part of this clinical picture. Is what I would, if I could say anything in this way, is you might be. It's like communication. You might be the best dentist, but if you cannot communicate a treatment plan to your patient doesn't get it. Similarly, the record keeping is now a very important skill factor which you have to have.
Yes.
And this is where I think I would like to say. The newer graduates are coming out who are much savvy with all the software, picking things up and able to keep these records a lot better. But it doesn't mean that we can't all lead to particular standardization. Change is very hard for all of us, and that's an aspect which we just have to take small few steps. A perfect example, you might write still the scale and clean done, and with the 114, you might have an intraoral camera. It doesn't matter if it's an old one or a new one. You take a picture of the calculus before and you take a picture after the clean after. And one, it's a communication tool. Two, it's an evidence base to show to the health fund or anyone else a question saying, hey, I've done the scale and clean. Look at that. It's a difference in this. That's I'd say,
that all makes sense. So in broad terms, just I suppose to wrap it up, Amit, we're talking about the old adage of prevention being better than cure. I think is the thing, really the key for audits. What other steps or anything maybe that we haven't covered can dental professionals do to protect themselves or prevent any issues? Maybe even things with looking out for front desk and what they might be doing. We haven't covered off on that.
No, you're right, Colm. And I think the buck stops with the practitioner. So it's very important that the entire team is up to date with what's happening. A lot of time when audits happen, the first step will be the front desk being told to send all the records through. But when they say all the records through, a lot of time the front desk doesn't even have an idea what does all the records mean. How much information is too much information and how much information should be provided. For example, you might have the lab slips which are kept in a separate folder. But if they are being asked for a certain patient which is on a crown, that lab slip has to be included as part of the record. And that is something which again the practitioner and the owner of the practice has to bring the entire practice from the dental assistant to the front desk all along this journey, so that this information is actually utilized.
Number one, that it's saved. First of all, the importance of keeping it and saving, and then in the as you say, that it's utilized.
So save it. be it accessible. The
Yes.
information has to be accessible.
Good point.
If you're taking digital camera pictures, make sure those pictures are regularly downloaded and saved to the patient files. If you have thousands of pictures saved on your camera,
Yeah.
when you are questioned for it and you have to go back looking for it, it's a hard stall. So you have to have a way to make things, having systems in place, protocols in place to have all this information stored properly, securely, with privacy is very important, which can then later on be utilized if ever there's a question. That reduces the stress, because as we mentioned before, when the audit letter coming in, automatically members are stressed. So if you can have things in a synchronized manner from day one, it saves that stress levels later when it comes to respond, or even passing that information on to DPLA or to ADA to help you, because then we have all the information, we can guide you in a proper format to go from there. So I'd say those are the main steps which dentists can do. Get the team along. Another very common one is keep up to date. We love listening to clinical podcasts. We love listening to what are the latest in piezo surgeries, lasers, implants, latest topics, minimally invasive dentistry, immediate dentine sealing. But this part, which may seem a lot more dry and boring,
and just in the admin
side of it, is as important. It does add to your CPDs also, but it also plays a big role in running the practice smoothly, and it saves you a lot of headache in the long run. Because as I said, you could be the best dentist, but if you don't have records to prove it, then it's no use.
Thank you, Amit. That is so helpful. It's been quite a long talk this morning, but it's been so much information in there and so helpful for our members. So I really want to thank you for that relevant and helpful context.
I'd say thank you, Colm. Most importantly, thank you for giving me the opportunity about DPLA and for being able to voice out some of the most common questions. Because one of the things with these things are the people who ask, there'll be one member who asks, but 20 others who are listening to it. So sometimes these podcasts, when people listen to it, say, I was thinking of the question, but I was too hesitant to ask. And if this particular podcast can even answer one or two of those questions which members have in their mind, but have been afraid to either ask or just haven't had the time, then I think it's worthwhile. So thank you for giving me the opportunity for that.
I agree. And we hope that this podcast was helpful to all our listeners out there, and look forward to sharing more guidance with you all in the future. If you like dental protection podcasts and would like to hear more, please subscribe and leave a review.